Pune, and 2 other private universities. And he was the president of Indian Psychiatric Society, president of Psychiatric Federation, and the president of Association of Industrial Psychiatry of India. And he was the board of member of Asian Psychiatric Federation, board member, and Zone 16 representative of World Psychiatric Association. And our second chairperson, I'd like to introduce her also, Professor Jhunu Shamsu Nahar Madam. He is the former chairman of Department of Psychiatry in Bangabandhu Sheikh Mujib Medical University, Dhaka. She was the first past president of Bangladesh Association of Child and Adolescent Mental Health and current president of Association of Therapeutic Counselor, Bangladesh. And she also was the past vice president of Bangladesh Association of Psychiatrists. I'd like to clap all the chairs from the audience, and I'd like to request our honorable chairperson to come on the stage and take their respected seats. Thank you. With the permission of our chairperson, I would like to represent our 3 speakers for these plenary 3 sessions. For this plenary 3 session, we have 3 speakers. Our first speaker is from Bangladesh, Professor Mohammad M.S.I. Mullik. He was the child psychiatrist, first child psychiatrist of Bangladesh, and he will present about the child and adolescent mental health care, challenges and prevention. Our second speaker, Dr. Ashim Mehra from India. He will present about the mental health care in today's world, challenges and preventive strategies. Our third speaker is Professor Pradeep Kumar Saha from India. He will present about the long-term treatment in schizophrenia, what defines the treatment, success in clinical and real-world settings. And these are our 3 speakers for these plenary sessions, and they will get 20 minutes for each session. And for your kind information, our first ring will be belled at 15 minutes, second ring will be belled at 18 minutes, and our final bell will be ring at 20 minutes, and screen will be off. So make sure the speakers will allocate their time properly. So now I'd like to, with the permission of our chair, I'd like to request our first speaker, Professor M.S.I. Mullik sir from Bangladesh. He will present the child and adolescent mental health care, challenges and prevention. I'd like to tell a brief biography of our first speaker, Professor Mohammad M.S.I. Mullik sir. He is the founding head of the Child and Adolescent Psychiatric Division of Department of Psychiatry, Bangabandhu Sheikh Mujib Medical University, Dhaka. And he is retired from Professor of Child and Adolescent Psychiatry, Bangabandhu Sheikh Mujib Medical University, and currently working as a chair, Faculty of Psychiatry, BCPS. So I'd like to request sir to present your today's topic. Thank you. Here's a pen and paper. If you want something, you can write it.
Talking about children is our joy, our passion, our happiness. And talking about children's mental health is undoubtedly related with the present and future of psychiatry and mental health. Honorable chairs, distinguished participants, I would like to say a few words on child and adolescent mental health care and mentioning the important challenges and prevention. My talk plan is that I will try to highlight major changes of child and adolescent mental health issues and its cumulative effect. I will try to focus the key concerned child and adolescent mental health problems in this country and throughout the globe and the major challenges related to this problem. I will try to point out the areas of proposed actions to prevent these problems, and I will try to state few prevention strategies and techniques related to child and adolescent mental health, and a brief conclusion remarks at the end. Though child psychiatry or child mental health is integrally related with the history of psychiatry and mental health, but if we consider the modern era of child and adolescent mental health, it is just started in the last century. In terms of identification of the case and defining child psychiatric problem, classification, nosology, and the assessment and the interventional, all interventional measures developed during the last century. And to date, if we consider the advancement of psychiatry, surprisingly, the huge advancement happens with the child and adolescent psychiatry in the last couple of decades. In Bangladesh, the formal child adolescent psychiatry just starts in 1998, and to date, it is so small time in relation to the vast history of psychiatry, but we have achieved a significant areas. I would not like to describe in details, but we know that we have some formal service, we have teaching and training facilities, and we have service modalities including psychosocial and pharmacological intervention. However, if we consider the development of child and adolescent psychiatry and mental health throughout the globe, unfortunately, this progress is totally disappropriate and disproportionate in terms of service, in terms of the availability of the service throughout the globe, and also there is disproportionate mental health, child mental health care within the country in different areas. Let us see the important areas of child adolescent mental health issues with new look. The rate is steadily increasing from 1.10 to 1 in 6. Despite of all efforts, this is not only related with the child and adolescent mental health, almost all psychiatric disorder, the prevalence is increasing despite of all manpower, all efforts. Not only in Bangladesh, it is this scenario exists throughout the globe. Even the highly advanced countries who actually involved with money and manpower. The cause is different. This is not the issue here, but if we consider this one, the etiological aspect of child mental health is actually worse than before. And increasingly more in transitional period. That means in the boyhood to adolescent, in adolescent, transitional period from adolescent to young adult, these critical terminal stages are actually very risk period of developing child and adolescent psychiatric problem. And during COVID pandemic, it has jumped over 2 to 3 times if we consider the meta-analysis of the epidemiology during and after COVID. And the researchers predict that the effect of pandemic over the increasing rate or prevalence will remain at least another 2 years. However, the impact of these high prevalence rate possibly will continue years after year. Considering the types, there is significantly increased rate of autism, depression, suicide, self-harm, oppositional conduct and substance misuses. Emergence of new problems. Also, we can consider the behavioral addiction, particularly the internet-related addiction. And the problem related with the maltreatment of the children is increasingly high. And surprisingly, considerable amount of adolescents can diagnosed as a personality disorder in this, and this is such an increasing problem. The researchers recognize that it can be diagnosed before 18. Also, surprisingly, it has been found that the psychosis among adolescents is significantly increasing. Considering the etiology, in the development of neurobiological research and the psychosocial research, we have a good idea about the etiological aspect of child psychiatric disorder. But as it is advancing, it has been found that it is not so easy as it was believed earlier. It is increasingly complex than before. And the interacting nature of diverse negative determinants that is ranged from the domestic violence to the global atmospheric change, all has severe interacting contribution in developing child psychiatric disorder. Though the molecular biology clears that the etiology of ADHD and some highlights of autism and also the childhood psychosis, it has been found that considering the two major issues, gene and environment interaction, environmental factor appears to play a greater role than the genetic issues. And surprisingly, it has been found that the onset of psychosis in children and late children and adolescents, the environmental factor is dominating etiological factor than the genetic factor. Considering the continuity, about the 60% and above child and adolescent psychiatric disorder can continue through the adulthood. It is particularly true for neurodevelopmental disorder. It is possibly majority of them is a lifelong continuum. However, the early depression, the social phobia, the different types of anxiety and behavioral problems, all are strong continuity over the adulthood. So if you do not consider these things into the early childhood, the burden of adult psychiatry or other branches of psychiatry will be so huge it can be collapsed. Considering the impact of the disorder is substantially high. And if we consider before and after COVID, the impact over the child in terms of academic underachievement and interpersonal difficulties are so high that makes a handicapped adults. Considering the burden over families, burden over services and burden over society, or in other words, the burden over the economy, burden over the advancement, the child mental health problems is hugely high. And during COVID, it has the burden of overall child and adolescent psychiatric disorder is nearly 3 to 4 times higher than before. Considering the intervention, there is no way for self-satisfaction. Low coverage of child mental health problem, like the adult problem also. There is vast discrepancy between the service need and the provision of service. There is no established referral from different tiers of service, and the referral is mostly ineffective because of underdiagnosed or wrong diagnosis. Because the child usually somatizes much more than the adult, and they usually misreferred, and that causes a huge number of loss of money, time, and the reinforcing nature of these all issues. And certainly there is a huge lack of psychosocial intervention, as it is much more important in managing child and adolescent psychiatric problem. Considering all the raising psychiatric problem of child psychiatric period, I would like to highlight these 5 important areas that actually really a burning issue now and near future throughout the globe and also within the country. These are depression, suicide and self-harm, addiction, autism and other neurodevelopmental disorder, and the comorbidities. I would like to few words about depression, that it is the cardinal burning issue and growing public health concern. Surprisingly and disappointedly, the rate is increasing from 2 to 8% to 10 to 13%. This disorder is seriously related with suicide and self-harm, and unfortunately, in terms of outcome of managing of childhood depression, the significant proportion are actually treatment refractory, particularly refractory to any type of antidepressant. A really burning problem. Considering suicide, the crucial public health problem in children and adolescents, and third leading cause of death among them. And this trend is increasing despite of all amenities. And again, the suicide rate is seriously higher, about 2 to 3 times than the girls. Self-harm is increasing in the same way, about increased by 25% and within 2 decades. And in 9% of the teens engaged in digital self-harm. It is really a alarming issues that actually enhances self-harm. Considering addiction, high rates of substance misuse already exist almost all spheres. However, this cyberbullying is added issue of techno-addiction, and all types of addiction is a risk factor of depression and other disorder. ASD is also, neurodevelopmental disorder is another increasing rate, though there is a debate whether it is the problem of the diagnostic criteria identifying the cases, or it is related with actual increasing problem due to genetic and the environmental interaction. Concerning comorbidities, it is also surprisingly increasing. About 40% child and adolescent has more than another child and adolescent psychiatric problem. And they also related with the co-occurring physical illness also. So that actually makes a very turmoiling in managing the child psychiatric problem in clinical practice, because if we don't consider all the comorbidities issue in an axial way, we will miss and the outcome of treatment will be low. I will just now try to highlight the major barrier: low understanding, low concern, low investment on child and adolescent mental health, incomprehensive plan, scarcity of resources, inequality in the distribution of resources, and increasingly unfavorable nurture. That last one is very, very important issue, because up to this age, the home, particularly the home of the child, was relatively safe than before. It is now really hurts at now. Considering the proposed action, we have to fix the research priority, we have to revise a strategic plan, and we have to redesign the child and adolescent mental health services. Considering the research priority, the most important research question should be on that what type of research can quickly possible to translate into the clinical practice. And the exploring protective factor is another important area of our research priority. Revising a strategic plan, we have to consider the cost-effective prevention and intervention. As it has been proved by the researcher that though the systemic services is very good for child and adolescent mental health prevention, but it is neither affordable nor practical. This issue is particularly true for us and also true for the developed countries. So the main strategic plan is that non-specialist based service, that is the important example of task shifting and task sharing, and redefining the role of mental health specialist. They will provide the specialty service, as well as they should act as a trainer, act as a supervisor, act as a monitor, act as a reviewer in terms of the service provided by the non-specialists. We have to provide much more funding for sick children and families, because we have to provide service at home of the sick children, rather than in the hospital or in the general setup. It is better to provide much more support to the family. We have to develop and support effective models of school mental health care. That is important issue, because we have a huge potential manpower. If we can utilize them, that could be much better for providing mental health services. And this is most important, that the telehealth service, majority of the service is now can be provided by the tele-mental health. Preventive strategies mainly is the education. We have to provide more education than to provide the actual service. The prevention is much more important than before. So there is a lot of preventive strategies. I am not going to much more about this detail. So in conclusion, we can say that new look is necessary to evaluate established facts and findings on child and adolescent mental health. What we know, it is not true. We have to go much more detail to consider child and adolescent mental health issues. Existing care is insufficient and inefficient to combat the huge needs. We have to, there is urgent need to redesigning the services, and establishing this system of cooperation is essential. And children's mental health actually matters. We have to raise to voice that children's mental health matters. Yes, it matters. Thank you so much.
Thank you, Professor Mohammad M.S.I. Malik sir, for your excellent presentation. Now I'd like to request our second presenter, Dr. Ashim Mehra from India. He will present about the mental health care in today's world, challenges and preventive strategies. I'd like to, okay.
Very good morning to all. First, I would like to thank to the organizers to provide me this opportunity to have an interactive session with such a lovely audience. With this, today I am going to talk about the mental health care in today's world, challenges and the preventive strategies. As here everyone aware is that mental health can be understood as a state of mental well-being that enable the people to cope with the stresses of life, to realize their abilities, learn and work well, and also contribute to their society. Mental health is one of the integral component of the health which enable a person to make decisions, to build the relationship and shape the world in which we live in. And it is one of the basic human right of every individual. A good mental health is a basic human right, and it is also very crucial for the development of the self, community and the socio-economic development of the country. As shown in the chart that over a period of time, the prevalence rate of psychiatric illness, irrespective of diagnosis, is increasing gradually over a period of time. And one of the reports says that across the world there was an increase in the incidence rate by 13% from 2007 to 2017. And in last few years, because of various crises like because of pandemic, economic dislocation, the strikes and the tussles among the country lead to sudden rise in the prevalence rate of psychiatric disorders. And during the pandemic, it was found that there was a 25% to 50% increase in the psychiatric illness. More common were anxiety and depressive disorders, and it was more common among the youth population. And despite of that, more than half of the person with mental illness did not receive any form of treatment. When we look at the SAARC country, the scenario is almost similar, that the prevalence rate of psychiatric disorders is increasing over a period of time. And when we look at the Asia's access to mental health treatment, what study shown that the country like India, Bangladesh, Nepal, Pakistan, they have a poor access to the mental health treatment, and it is expected that because of that it can have a great impact on the economic development of these countries. And apart from that, the other concerns in today's world health are today's era. One of is the suicide rate. It is seen that at least 1% of the total death comprises of because of suicides. And surprisingly, more than half of the death occur in young adult or middle-aged populations. And other than that, mental health illness can lead, which is one of the leading cause of the disability, causing 1 in 6 years live with the disability. And because of mental illness, the life expectancy is also very less compared to the general population, which is reduced by 10 to 20 years because of various reasons, like these people are more vulnerable to the physical illness, having nutritional deficiency or having metabolic disease. And it also leads to socio-economic inequalities. Coming to the challenges in today's era, one of the basic difficulties is that access to the mental health care. Everyone talking about this since yesterday also a lot of talk about this, that still people are not able to access to the mental health care. And it might be because of various reasons like limited availability of mental health providers. When we look at the data, though there is a recommendation from the WHO, but when we look at the country like India, Bangladesh, like SAARC country, the requirement is very less. Still we are lagging too much behind as per the requirement. Apart from that, still in our countries, stigma and discrimination toward the mental health is still there. And there is also lack of inertia from the government because they are providing inadequate fund. They are not, there is a lack of promotional activity, etc. And the other issues like that, still we have the broken care ecosystem. Means still the people are getting the care from the tertiary center or even small pocket. We are not able to reach the remote area, undeserved area. And still people, there is a high out-of-pocket cost. Still in country, people are not insured for the mental health problems. Even this is one of the report from the Bangladesh in which they stated that more than 90% of the people with mental illness were not able to reach the treatment. And this scenario is almost similar in other neighboring country also. And when we look at the, as I already mentioned, that still people are not getting insurance for the mental health illness or mental health related problems. This is one of the reported in which they says that still in Bangladesh that there are more than 160 million population, and still only about 400 psychiatrists are there to deal with the mental health problem with such a huge population. And even they also report that as per them that currently more than 15 million people are suffering from mental illness. And the difficulty with the mental illness is that it can lead to diminished productivity, higher unemployment, an increase in the physical illnesses, higher burden on the existing health infrastructure, And also the other basic challenge in today's era that our services, our research is failed to attract the sufficient attention and funding. And the other basic challenges are that already mentioned, that limited infrastructure with a poor referral system, limited community awareness, there is a shortage of human resources, and still the mental health services are not integrated with the primary health care and not integrated into specialized services like with other chronic disease like AIDS, etc. And still there is a poverty and social deprivations. Now coming to the promotion and preventive strategies, this is the public mental health conceptual model derived from the WHO framework. So, for the promotion and prevention of mental illness, mental health related problem, it is very essential to identify the individual, social and structural determinant of the mental health. So, there is a need to intervene or need to work upon these individual or specific group or the whole population according to their determinants. And also there is a need to intervene to reduce the risk, build resilience and establish supportive environments. For occurrence of the mental health problem, basically we have to understand that who we are, what is our biology, what is our genes, from where we are belongs, from which socioeconomic status, gender, race, employment status, and where we are living, with whom we are living, like our peer group, family, community members, work or social condition. So there are factors like neighborhood poverty, crime, racism, social inequality, housing quality. These can lead to mental health problems. So we have to invest in these protective factors, like improve neighborhood conditions, affordable housing, providing job opportunities, safe spaces for community connection, so that we can at least work in a way to prevent the occurrence of the mental health problem, because of these are the modifiable factor. And apart from that, there is also need to deepen the value and commitment we give to the mental health. So there is a need to stepping up the investments to provide appropriate funding to work on the human resources, as I already mentioned by sir in the previous session, and also need to work on other resources. So for other resources, there is a need of committed leadership to pursue on evidence-based policies and practice, and establish the robust information and monitoring system. Also, those people with mental health, there is a need to work with all aspects of the society and decision making, and there is a need to reduce the disparities and to promote the social justice. The other issue that is there is a need to reshape the environment that can influence the mental health. So there is a need from government and from other society, that there is a need from legal cells, like there is need to implement the concrete action to improve the environment for mental health issues, like strict action against those who are against the intimate partner violence, against the abuse and neglect of the children, more vulnerable population like elderly people. So there is a need to implement strict laws. And also there is a need to strengthen the mental health care by changing where, how and by whom mental health care is delivered and received. So there is a need to build the community-based network of interconnected service. And also there is a need to diversify and scaling up the care option for common mental health conditions. Like already mentioned by sir, there is a need to work on task sharing approach, use digital technique to support the guided and self to deliver the mental health. And also there is a comprehensive mental health action plan from 2013 to 2030 recommended by WHO member states. As per them, that basic aim of this plan is to improve the mental health by strengthening the effective leadership and governance, to provide the comprehensive, integrated and responsive community-based care, to implement the promotion and prevention strategies, and to strengthen the information system and evidence and research. And in terms of treatment, the community-based health mental care should be accessible and acceptable to everyone. And also there is a need to work upon the ecosystem of the care. So basically there are five shifts to improve the ecosystem of the care, like to expand the mental health workshop, transform the user navigation experience, catalyze the development of recognized innovative models, increase public and private insurance coverage, and reform the payment systems. Under the expanded mental health workforce, there is a need to invest in community mental health work training program, engage the retiring people as a service providers, to augment the training program to inspire the professionals so that they can work in underserved area or remote area, but at the same time there is a need to provide some benefit to those health professionals. The second aim is expand the mental health workforce by investing in community mental health training programs at the school level, college level, increase in the community mental health support capacity, and also to involve the people from community like faith-based organizer, barbershop, so that they can be trained in such a way that they can aware the people about the mental health problems. And the next one is to transform the user navigation experience by tracking the local mental health needs and a digital mental health crisis support platform. And also there is a need to create a digital mental health crisis support platform so that they can respond to mental health crises locally as well as regionally. And there is a need to integrated behavioral and primary care model at clubhouses, mobile and home-based care, etc. And also there is a need to reform the payment systems so that there is a need to reduce the work-based pencil paperwork, and also need to enhance the existing infrastructure. With this, thank you all.
Thank you, Honorable Speaker, Dr. Ashim Mehra, for your excellent presentation. Now I'd like to request our third speaker, Professor Pradeep Kumar Saha from India, who will present the long-term treatment in schizophrenia, what defines the treatment success in clinical world setting. And I'd like to request our speaker to maintain the time because we are running out the time right now. Thank you.
Excuse me, madam. Excuse me. 20 minutes. Yes. Okay, stick to that. You have time. Very good morning to all of you. I must thank and respected chairpersons, and I must also thank the organizer in the sense that I got the opportunity to say something about my subjects in front of this August gatherings. So first of all, I'd like to say that the features of schizophrenia. If you know, so there is a long-term schizophrenia, it can induce the cognitive deficits. Not only the positive symptoms and negative symptoms, there is a definite progressive brain tissue loss with every psychotic relapse. And in addition to that, all the things leads to the social and occupational dysfunctions of the patients. In addition to that, inability to work, inability to meet or to form relationship, and as well as impairs self-care. And if we consider from our parts, there is a development in treatments of schizophrenia since 1930. First is the ECT. In 50 we got the chlorpromazine. In 60 we got a lot of antipsychotics, haloperidol, fluphenazine, thyroidazine, loxapine, varfenazine. Everybody knows. But I am just repeating this sense that in 1970 we got the wonderful drug, the clozapine. And
The 2002 we got Respiridon, olanzapine, so-called atypical antipsychotics. And from 2003 to 2008, we got another beautiful drugs, Respiridon, Consta, Paliperidone, and Zuclopen salts. And if you see the effect size of 10-second generations of antipsychotic. Number 1 is clozapine, next is amisulpride, third is Respiridone, and so on. I'm not going details. I think every psychiatrist knows about this. But what are the causes of relapse that fuels the deterioration in schizophrenia? With each relapse, everybody knows a lot, but what are the key things we should keep in our mind when treating a patient? You thinking that it might be a schizophrenia. There's a progressive loss of gray and white matter loss. In addition to that, there's a response will be slower and less complete, and more frequent admissions to the hospitals. That illness can become more resistant to treatment and going to be harder for our psychiatrist. And patient has a loss of self-esteem and social and vocational disruptions. As you know that among the schizophrenic, those who are after getting the improvements, the 4 to 10% used to commit suicide. And there's an increased burden on the families, caregivers, as a whole, the whole country. I think every people knows that every year the United States of America is spending $150 billion only for the schizophrenic patients. And the discontinuation of the medication schizophrenia occurs in both an early and chronic phases of the illness. But what is the impact of this? If you go through the CATI studies, is very popular studies. I am not going details. The treatment discontinuations, if you consider all the causes, in case of ziprofazine is highest, 79%. Next is Respiridone. Less is olanzapine. Third, if you consider the CAFE studies, a randomized double-blind 52-week comparison of the olanzapine, clozapine, and Respiridones, what you found? The CAFE calls treatment discontinuations. So discontinuation of treatment is a burden for us, and the patient's own involvement is highest. Patient's decisions. What might be the reason? Many people, many psychiatrists used to think that due to side effects. No, it is the decision of the patient itself. Inadequate therapeutic effects is also contribute, but it's less, and administrative procedures also. Whether it may be oral or parenteral, you have to take decision. You are the best judge for your own patients. And if you see the non-adherence in different categories, the weight reductions, 96%. And less one is headache. That is 30%. And you see the schizophrenia among the highest, 91%. So always when you're treating a patient of schizophrenia, you have to educate the patient, patient party, and others in such a way that we can prevent this non-adherence. There is a non-adherence in many ways. Non-adherence to the doctors. There is a lot of things of doctor shopping. The family and the patient is induced. And drug also. And your preference of drug. So we have to be careful regarding the non-adherence. And next question is, why poor compliance is a major problem when you're treating a long-term treatment of schizophrenia? The first and foremost things everybody knows, that is the denial of illness, that is the anoxonosia, and as well as the cognitive impairment. Definitely, initially schizophrenic people don't have any cognitive impairments, but year after year there is a lot of cognitive impairments. That memory functions and executive frontal lobe functions is also giving a big part and role, and negative symptoms also responsible. Side effects already have mentioned, and the most important thing is most of the cases of schizophrenia, we used to think that chaotic lifestyles. You know, chaotic lifestyle including this substance abuse also. Somebody is taking cannabis, alcohol, and both like this. And the most important thing is we should keep in our minds that the nature, the human nature is partial compliance. Many people also used to think take the medicines in due time. So that is also considered. And partial adherence plus hospitalizations, it is the vice versa. Adherence is more, less is hospitalizations. And adherence is less, more is hospitalizations. And now coming straightway to the progressive MRI changes over first, second and third episodes. If you see the first episodes and third episode, there is a difference, there is shrinkage of the brain. And see the size of the ventricle gradually increasing. So there is one schematic presentation. So you see the MRI schematic progression in schizophrenia, there is the first episode and the fourth episodes. Ventricle gradually losing and bigger to bigger. So ventricular enlargement has to be the poor outcome of the patients. And I think for the long duration peoples, every psychiatric patients go for the MRI. But we are developing countries, many times it is not possible. But if it is possible, the person is convinced and there is a free set of, then you can definitely go for the MRI. And next coming the brain volume changes in the first episode of schizophrenia to a 1-year follow-up study. If we consider what the pictures will come, the picture on the first episode of schizophrenia, if you compare with the masked healthy controls, you will see outcome measures for 2 years, the total brain volume and cerebral gray volume significantly decreased and lateral ventricular volume and significantly increased in patients compared with controls. So one is decreased, one is increased, and decrease in global gray matter volume significantly. So there is a presentation significant progress gray matter. The first one, the bluish, is a normal, and the schizophrenic you see and see the difference. It was published by Thompson and his associates in 2000s, and p-value I have mentioned here, so please go through this. And now coming to what components of the brain tissue are lost during each psychotic relapse. So you should know that. What are the areas of brain tissues are more specifically involved? That is the shrinkage, the dendritic length by 50%. And in the number and size of dendritic spines, also reduced a lot. And in the size, there is a contraction of neuroid extensions. And already I have mentioned that also in the glial cells. You see the picture, original presentations of the bright field photomicrographs of illustrating Golgi impregnated basilar dendrites and spines on dorsolateral prefrontal cortex. So that area of the brain is very much popular for the psychiatrist, with a 3-layer pyramidal neurons from normal control subjects. So see the A, B, C. If they compare, then automatically you will realize nothing to say more, as time is only 20 minutes. I will ask my chairpersons at least they consider 2 minutes more. So decline in neurotropic factors in schizophrenia. See, there is a neurotropin, there is a reduction in nerve growth factor as well as brain-derived growth factor BDNF. We are very much popular with BDNF, but not very much popular with neurotropin and nerve growth factors. But you should be, keep in your minds, these 3 areas are very much involved in most of the cases of schizophrenic patients. But the question is, what are the possible mechanisms? Till today, we do not know. Nobody can give the answers, but there are a lot of hypotheses if you go through the journal. I have enumerated few things. The dopamine overstimulation that leads to cell death. And it was published by Ben Sech and his associates in 2004. Next is glutamate excitotoxicity. The DAY-2 et al. 2001. GABA dysfunctions, Farber et al. 2003. It is nowadays very popular. And impaired anti-adaptive signaling. The Dotto and his associates in 1999. And mitochondrial dysfunctions, Beelan et al. Decreased nitric oxide biosynthesis, Fiskas in 2002. Hypercortisolemia is also given by the idea with the McQueen 2004, and oxidative stress or free radicals also in one concept in 2004. So the next is coming is neuroplasticity. I think everybody knows what is neuroplasticity, but I would like to add a few dendrite spines, synaptic remodeling, axonal sprouting, long-term potentiation, neuroid extensions, synaptogenesis, and neurogenesis, that means neurons and the glia. I'm not going details, but one thing you should mention here, there is a landmark and dogma-shattering discovery. There's Erickson and his associates demonstrated that functional neurons can in fact be generated in the adult human brain in several neurogenic regions, including the most specifically, there's a dentate gyrus of the hippocampus and subventricular zone. So these are the two areas we can expect, and the surviving cells differentiate into neurons or glia, and then their newly formed dendrites start receiving what? Glutamatergic input, and then join the ranks of the existing neuronal network. This idea, an established idea, has given by Song et al., and it was published in Nature Medicines, one of the best journal in 1998, the Erickson. So next time coming to the atypical antipsychotics. We got a very, very good weapons, and it is available, I think, in Bangladesh, in every corner of the Bangladesh. There's atypical antipsychotics has been shown to be neuroprotective. That is a very good news for us, and published studies show atypicals can prevent progressive brain tissue loss associated with psychosis and stimulate neuroid extension and neurogenesis and cell survival. I got 2 minutes extra. And animal studies of neurogenesis and antipsychotics, second generation antipsychotics, in contrast to haloperidol, several atypical antipsychotics reported to stimulate neurogenesis in rats. The olanzapine, risperidone, paliperidone, I'm not going details as time is short. And if anybody is interested, you can go through this Journal of Neuroscience Research. The atypical neuroleptics stimulate neurogenesis in adult rat brain. There's animal studies. And atypical antipsychotics and neurogenesis is subventricular zone. Already I have mentioned, so I'm not going details. So anybody is interested, Journal of Psychiatric Research, there is a differential effects of typical and atypical antipsychotics on nerve growth factors. It was published by Vinay Parekh. So you can go through these articles and you'll get some ideas. And how is remission in schizophrenia defined and quantified? So see, the PANS is very popular, but anybody can tell me, anybody can tell me that if you go for the PANS for the normal people, what should be the score? Anybody else, any among the students? If I go for the PANS score for the normal people, okay, I am telling you. See, this is 30, and the normal people with the stress, it is 35 to 40. But the acute psychosis is 95 to 100, and then you have to hospitalize these patients. And at what time you have to discharge? 80 to 85. And when the patient, you say the patient is stable, fit for marriage, that is 50 to 55. Okay? The next is revision criteria for schizophrenia. That is a P1, P2, P3, I'm not going details. Z9, Z5, and N2, N1, N4, N6. So these are the criteria for the time criteria for the 6 months. How many long you should continue? The 6 months. And the PAN scale level I already have mentioned for the normal peoples. And see, I'm going to tell you the case history which was presented to the FDA for approval of the long injecting applicable for the schizophrenia. Whether it is a risperidone. Pardon? Yeah, within 2 minutes. I need 2 minutes. So 34 years, single male living in a group home and paranoid schizophrenia, single age 16s, and symptoms already hallucinations and TV actors talk to him and paranoid delusions or disorganized thinking, and many relapses due to erratic compliance, and 8/28 switch from haloperidol to oral risperidone, but better tolerability and his poor compliance continued, but consented to the participate in the long-acting injectables for as per advice of the FDA, and responded well and agreed to enter the open label. And 25 milligrams since twice in a week, patient become very stable and his PANS dropped from 85 to 49. The next one, in the second, the then applied to community college to study history, and family has been very pleased to his significant and prolonged improvement and have reintegrated from his family. Over the next 3 years, the patient shows full effect, good judgments and insight and motivation, has returned to dating and socializing. I am not going to the second case which was presented to the FDA. I am going to the straightway, the logic of long-acting injectable paliperidol antipsychotic therapy in schizophrenia. The psychotic relapses are neurotoxic with progressive brain tissue loss. Antipsychotic reverse acute psychosis and prevent relapses. Long-acting injectable antipsychotics exert significantly better protection from relapse than an oral antipsychotics. Atypical induce neurotropins and neurogenesis and help regenerate brain tissue and functioning, and typical antipsychotics do not. And how long you should continue the oral preparation and injectables past 3 weeks, then discontinue the oral preparations. The next is conclusion is the paradigm shift in the treatment of schizophrenia must be adopted. I think the Bangladeshi psychiatrists are using these long-actings injectable. The use of long-acting injectable are typical early in the illness to protect against the inevitable non-adherence and trajectory of the schizophrenia from deterioration to stability, remission and recovery. And the use of injectable achieving a lasting remission that leads to functional recovery is the ultimate goal of schizophrenia. 100% adherence less will continue the vicious cycle of relapses, deterioration, disability and poor outcome in schizophrenia. Thank you. Thank you.
Thank you, sir. Due to shortage of time, we don't have any time to take any question and answer session. And next will be provided by Fatima, please.
Thank you, sir. Now, it was a very mesmerizing presentation from all the speakers. A big round of applause from the audience for the speakers. Now, this is the time for praise giving ceremony. First of all, I'd like to request our first speaker to give the crest to our first speaker. I'd like to request Professor Junu Shamsun Nahar, Madam, to hand it over the crest to our first speaker, Professor MSI Mollik, sir. Sir, please come on the stage and take your crest from the ma'am. Now I'd like to request Professor MSVK Raju sir to hand it over the crest to our second speaker, Dr. Ashim Mehra. Please, Dr. Ashim Mehra, come on the stage and take your crest. Now our third speaker, I'd like to request Professor Pradeep Kumar Saha for his excellent presentation. I'd like to request Professor Jhunu Shamsul Nahar Madam to hand it over the crest to Professor Pradeep Kumar Saha. Now, this is the crest giving ceremony to our Honorable Chairperson. I'd like to request Professor Abdul Muttalib sir to come on the stage and give the crest to our Professor M.S.V.K. Raju sir. Sir, please come on the stage and give the honorable crest to our chair. Now I'd like to request Professor Brigadier General Retired Ashraful Jamal Chaudhary sir to come on the stage and give the crest to our Professor Jhunu Shamsul Nahar Madam as a chairperson. Now I'd like to request Professor Pradeep Kumar Saha from India to hand it over the crest to our honorable chairperson. Please give a round of applause from the audience. Now, I'd like to request our Honorable Chairperson to say a few words as a closing remarks. Professor, I'd like to request our first Honorable Chairperson, Professor M.S.V.K. Raju sir, to please give some closing remarks speech about this plenary session. Okay.
That is a very wonderful session, no doubt about it. Our first speaker, Professor Muhammad M.S.I. Malik, my long-term colleague and friend, and he is the first child and adolescent psychiatrist in Bangladesh, and he is a very good researcher. And he said very appropriately that prevention strategies are the very important thing for child and adolescent psychiatry. And we have done significant advances in child and adolescent mental health in Bangladesh, especially regarding autism awareness and other aspects in child mental health. And we have established also neurodevelopmental trustee board for the betterment of a special child. I have to say, as Professor Malik said, that the effect of pandemic is really, this is a bad effect for psychiatric health among child and adolescent. And we have to take care of this. And of course, prevention strategies are the very, very important factors in this regard. And so we have to allocate more budget for service, research, awareness, etc. Regarding my our second presentation, Dr. Ashim Mehra, he has also presented very nicely, and I thank him very, very much for coming here and to deliver his speech. And he said a very important thing, that access to the mental health care, and really in our subcontinent it is difficult. Most of the people go to the traditional healers. So we have to disseminate our knowledge where we can get mental health services within our affordable limits. And he also said that integration of other non-communicable diseases is very, very important. And I admit that he said very appropriate things. And regarding our third speaker, Professor Pradeep Kumar Saha, he said that along with positive and negative symptoms of schizophrenia, there is cognitive deficits. And really, I went to a workshop in New York regarding cognitive remediation in psychiatry in schizophrenia in Columbia University. And there really I learned a lot from there regarding cognitive deficit and cognitive remediation. And discontinuations and medicines, he also said, and really there is a loss, a neuronal loss and brain loss if we discontinue our medicine. And so we have to be very careful, and with these few comments, I like to say thank you to all. Thank you very much, and I like to thank you, my and other chair, Brigadier Raju. Brigadier Raju, please.
I don't think I can hear anything. Good afternoon. Dr. Jhunu Nara has spoken, given her valuable comments on the three speakers. I don't think I have much to add, but I must tell all the speakers have dealt this respective topics in a great style. We wish we had more time to discuss on these issues, but unfortunately, because shortage of time, we had to suspend the discussions. And I congratulate all the three speakers for speaking so well on important issue of child mental health care and mental health care, and also the issue of antipsychotics in schizophrenia. Thank you.
Thank you, Honorable Chairperson, and thank you, Honorable audience, for your kind attention. This is the ending of our plenary session. This nice plenary session was sponsored by Unimed and UniHealth, and I'm signing out. I'm Dr. Fatima Zora signing out for right now, and it is handed over our plenary 4th session, and there is no break in between. Thank you.
Assalamu alaikum and a very good afternoon. It was an exhausting session last, I know, but there is no gap due to our time shortage. I would like to welcome you all in our plenary 4. I am Dr. Anika Basharat, a postgraduate student in psychiatry, currently working in Bangladesh. I would like to introduce our chair to you without any delay. Our chair will be Professor Bidhan Ranjan Roy Poddar for our this plenary 4. I would like to welcome Sir to the stage. Professor Bidhan Ranjan Roy Poddar is a professor and director of National Institute of Mental Health, Dhaka, Bangladesh. He is the executive committee member of Bangladesh Association of Psychiatrists. There will be 2 sessions. I would like to welcome our first presenter, Professor M.A. Mohit Kamal Sir, to the stage. He is the director cum professor in National Institute of Mental Health before, and he is the former General Secretary of Bangladesh Association of Psychiatrists. He is also current Vice President and a member of National Narcotics Control Board. There will be no question-answer session due to time constraints. The total time of first presentation will be 20 minutes, and there will be a bell on 15 minutes, another on 18 minutes.
Thank you all. It is my proud privilege to welcome the foreign delegates to Chattogram, the Chatrola, the port city of Bangladesh. We call in Bangla Bandon Nagori. একটু বাংলা বলতে ইচ্ছা করছে কারো সবাই বাংলা যারা চট্টগ্রামে এসেছেন তাদেরকে আমার এই প্রাণের শহরে প্রাণ ঢালা ভালোবাসা জানাচ্ছি অলরেডি 30 মিনিট অতিক্রান্ত হয়েছে I am very much proud of Anika or on that side of the slide presentation. We want to present the obsessive compulsive disorder during COVID-19 pandemic. Along with my research, my co-authors are Dr. Jillur Rahman Khan Ratan, our scientific secretary, and Dr. Nasim Jahan, very brilliant young star in my subject, and Dr. Mahabub Moik Rishad. He is an internal medicine specialist. During COVID, he was working as a COVID consultant, and also Dr. Muntasir Maruf. These are my team. So, introduction of my presentation. Pandemics have struck human societies since ancient time and caused millions of deaths, economic depressions, and many more. Since World Health Organization has declared a pandemic in March 2020, many strategies have been imposed worldwide. Fear of the virus and various strategies limits its spread might have negative impact on the mental health populations worldwide. According to recent literature, individuals who had been diagnosed with obsessive compulsive disorder may be the group most affected by the pandemic. OCD is associated with reduced quality of life, various comorbid mental disorders, and with severe OCD, an increased risk of suicidal attempts. As people with OCD are more susceptible to mental health impact of COVID-19, we aim to investigate the socio-demographic and other factors of OCD and relationship of its occurrence with the COVID-19. Methodology. Study design, a descriptive cross-sectional study. Place of study, a private consultation center of a psychiatrist, Dhaka. Period of study, April 2022 to June 2022. And selection criteria, all patients above age 18 having OCD and given consent. Sampling technique, it was a consecutive sampling, and sampling size, 153 patients were included in this study. Data collection instrument, consent form, consent was taken from every respondent. Diagnostic and statistic manual of mental disorder, DSM-5, semi-structured questionnaire prepared by the researchers after reviewing related articles from online research. Data processing and statistical analysis, computer software program statistical package for social science, version 2.5.0 for Windows. Ethical measures, all ethical measures were maintained properly. Result. Proportion of the new cases after pandemic among total cases, number 153, new cases number 28, about 18.3% among total case was significant. Proportion of the patient who was already diagnosed before pandemic, number 125, among them 40.8% was already on treatment, and 59.2% needed treatment after appearance of the pandemic. We want to show some parameters, especially age group. You can see 18 to 27, 54%, it's the highest. And regarding the sex, you can see the female were more sufferer, and it's 56.2%. And marital status, you can see unmarried, 54.9%. And residence, urban, 73.9%, highest. I am just focusing the main points and higher rates. Because of time constraint, I will go through within the limited time. Regarding literature review, we have seen education, we have seen higher secondary school was 39.9, and from higher secondary to onward, postgraduate and others, it was very big, 62.8%. We may have some discussion. We want to cite some informations. The etiology of OCD is largely unknown. It has heterogeneous presenting symptom. Any external stress cues might aggravate these symptoms. Main finding of our study were significant number of new cases of OCD patients and exacerbation of obsessive compulsive symptoms in old cases. An online study conducted among general public of UK, it has been shown that the OCD symptoms was rises during the COVID-19. At the same time, a study of Istanbul University and a study of Germany and a study of online study in Canada and also a online study in Saudi Arabia, that has been shown that the symptoms increases during the pandemic. One of the studies conducted in a private center of Bangladesh just before COVID pandemic showed similar socio-demographic finding. Most of the patients were from 21 to 30 years of age. In our study, the main age group of 29 plus minus 12. I have mentioned about the Saudi Arabia. In our family history was present, 23.5% responded. In a local study, 23 among 86 cases, 26.7% selected from 5 different hospitals and clinics of Dhaka city had family history of OCD. Regarding physical comorbidity, it was 55.6%. And in a local study with patients having severe mental illness, overall 45% of the respondents had the physical comorbidity, where diabetes 28% and hypertension 26%, disease of the skin was present among 1.3% of the respondents. In our study, 90% patients had suicidal attempt. So it is very significant result in our study. 19% had the suicidal attempt. Approximately 4 adults in general population report history of deliberate self-harm, and up to 1% report frequent involvement in such behavior. Deliberate self-harm was found in about 20% of the adults and 40 to 80% of the adolescents with the psychiatric disorder. OCD has been considered to be associated with a relatively low risk of suicide. Recent studies, on the contrary, revealed a significant association between OCD and the suicidal ideation or attempts. Limitations, sample size, I think it is small in relation to other studies I have mentioned, but the interview was face-to-face. In other study, you have seen online interview. And it was a purposive sampling. This is our limitations. And I think I have rushed to my conclusion. Significant proportion of the person with OCD experienced their symptoms first time during COVID outbreak. People both with and without diagnosed OCD prior to the pandemic generally experienced worsened OCD symptoms during the COVID-19 pandemic. However, the responses are heterogeneous and many factors other than the pandemic seem to be responsible to prevent the impairment of the symptom and the development of new cases, close monitoring of patient with OCD and education of the general public is essential. Literature is still limited to more national and multinational, cross-cultural and longitudinal studies are essential. Before showing the references, my own experience out of the range of this study was that in my private chamber or the chamber of our all psychiatrists, we have observed in Bangla, আমরা বলি স্রোতের মতো রোগী আসছে, সব রোগী ওসিডিতে ভরা। স্রোতের মতো রোগী আসছে, একের পর এক রোগী আসে, obsessive compulsive disorder. Step by all patients, most of the patients in our chamber coming with new OCD symptoms or old exacerbated OCD complications, and they are not having the response with any specific anti-OCD medications. We have seen one regime very good for one patient, but the same regime is not responding to the other patients. So these observation from the field, we have gone or we have planned for the study of this COVID for OCD during COVID time. Thank you all for patient hearing.
Thank you, Dr. Mohit Kamal sir, for your nice and short presentation. Now, this is the time for an interesting part of our presentation. This will be a debate done by two of our highly energetic ladies. And I would like to welcome our debaters, Professor Indira Sharma and Dr. Ruma Bhattacharya. Professor Indira Sharma is the former professor and head of the Department of Psychiatry in the Institute of Medical Sciences, Banaras Hindu University, Varanasi. She is currently Director of World Federation for Mental Health, member of Forensic Psychiatry, section of World Psychiatric Society, Chairperson of the Committee on Women, Mental Health, SARC Psychiatric Federation. She is also the former President of Indian Psychiatric Society and SARC Psychiatric Federation. Dr. Ruma Bhattacharya is a consultant psychiatrist. She is a Director Council member of Indian Psychiatric Society and co-chairperson of Committee Stigma and Mental Health of SARC Psychiatric Federation. She is former President of MP Branch and Secretary of MP Branch of the Indian Psychiatric Society, also founder of WOW, Words of Worth, and the Welfare Society that works toward awareness of mental health and eradication of stigma. Welcome them to stage.
I have given you my slide. Where is my slide? My pen drive. Do what you are doing. इसको पहला ये वाला नहीं आएगा. पहला का उसको पहला वाला निकालो उसको. Do what you are doing. Have you, is my presentation inside? Yes. Then open it. वो खोलो ना. Let us start. Yes, okay. Friends, today we shall have a debate on a very important topic. My right to have or not have my baby. Now, the primary roles of women have been childbearing and child rearing. Before 1971, Abortion was criminalized under section 312 IPC, and it was considered as causing miscarriage, and the provider was given 3 years imprisonment and or fine, and the woman 7 years imprisonment and or fine. However, in 1960s, abortion was made legal in 15 countries, and India reacted by forming the Shanti Lal Shah Committee in 1964, and thereafter we had the Medical Termination of Pregnancy Act in 1971, which was followed by amendments in 2002 and 2021. Now, looking at the indications for termination of pregnancy, the main indication was, as you can appreciate, the risk of life or grave injury to the mother or to the fetus. But while saying grave injury, it also included not just physical illness and death, but also mental ill health, and failure of contraception was also included, along with being raped, being a rape survivor. Whereas in 1971, the termination was allowed till 20 weeks. In 2021, the law became very liberal in cases of rape survivors after 24 weeks. And for substantial fetal abnormalities, there was no higher upper limit. It was more than 24 weeks. Now, with this, whenever the termination is required after 24 weeks, there was necessity for the medical board. And another important introduction was the confidentiality. The one who did the termination had to keep it secret, else the person would be fined or imprisoned for 1 year. Now the law in our country gave absolute rights to the mother under Article 21, said as reproductive right, but no right to the father. And the law became so liberal that it gave not only the right to the married woman, but also to the unmarried women who became pregnant out of live-in relationships or who were rape survivors. And to go further, even a change of marital status, say recently the woman had become widowed, or the husband had divorced, or the husband then also could get the pregnancy terminated. So you can see, with this, what happened was the judiciary became very, very liberal and sanctioned termination even in cases of advanced pregnancy when the life of the mother would be at risk. And in cases of rape survivor, in the Uttarakhand High Court, it allowed termination even though the medical board report said it is not safe. The court said, never mind, there is no point living with life without dignity. So this is the extent to which the courts went. And so with this background, I just would like to say what recently was done, which has shaken the world. And this is the United States Supreme Court judgment on January 2, 1973. Now here, this judgment is a landmark judgment. It invalidated all previous laws. All previous laws, and it allowed abortion more freely. It set guidelines for abortion, and it upheld the view that the right of privacy of a woman must be considered against important state interests in the regulation. And it said that in the first trimester, the woman had an absolute right for termination. So this was in 1973. And soon after, another litigation was there in the Supreme Court, which upheld the same judgment, except that it was not up till the first trimester, it was up till the period of viability, which is usually up till 24 weeks. So with this background came the next landmark judgment, which shook the world. And this is on June 24, 2022. It is a misprint, 2022. Now, in this judgment, it overruled Roe and Wade and Planned Parenthood versus Casey. And on the originalistic ground that the right to abortion cannot be found in the US Constitution, it prohibited abortion. Now this is a landmark judgment, and people reacted from all over the world. Leaders like Biden, President of United States, women's groups, many others have reported, the medical students, they have reacted and fiercely against this decision, and saying that my body, my right, my constitutional right to have or not to have my baby. And this is likely to have repercussions all over the world. Now, with this in background, today we are having a debate on this very important topic, my right to have my baby versus my right not to have my right not to have my baby versus my right to have my baby. Now, in this debate, the first speaker would be Dr. Ruma Bhattacharya, who will be speaking on my right not to have my baby. Dr. Ruma, please come forward.
This one?
Last one. Just go.
This one?
Yes, thank you. Thank you.
Come.
Contact next quarter. Yes, thank you. Yeah, good morning everyone. Can I hear a good morning? Good morning. Yeah, it's nice to see so many females in the auditorium. Yeah. So I think this is a very interesting debate, and I hope you all will pay attention. I am Dr. Ruma Bhattacharya from India, Bhopal. So every human has rights. Do we or don't we? Yeah, we do have rights. Yeah, we are supposed to have rights, isn't it? Yeah? Men included. Yeah, men included, transgenders included, everyone included. Yeah? So, abortion. So, abortion is a letter, one word, right? It's just a word. It has got 8 letters. Can you think of other controversial 8-letter words? Can you think of any controversial 8-letter words besides abortion? Delusion, marriage, religion, morality. Yeah? These are all 8-lettered words, and abortion is another. So abortion, pro-life or pro-choice? You decide. A woman's right over her body is denied in so many countries. Many Christian countries are against abortion. The Catholic Church is against it. Thou shalt not kill. So, is abortion anti-life? No, it is not anti-life. And it is definitely not murder. So what is abortion? Can someone say what is abortion? So let me define it. It is a procedure to end pregnancy. How is it done? By using medication or surgery to remove the embryo or the fetus and the placenta from the uterus of the mother. So does any of this sound fun? Is it like fun? Is it an adventure? On the contrary, abortion is painful, it is traumatic. It is far from fun. Women take every possible precaution so that they do not have to undergo abortion ever, until and unless it's like a compulsion, right? So why is this debate? To have or not to have my baby? There's been a few changes since the Republicans took over in an abortion clinic. So the Republicans say there is a 9-month waiting period. Yeah? By instinct, women do want to have babies, though nowadays a lot of women are opting out of it. That's okay. A lot of married couples are opting out of having babies. So have we got the whole debate wrong? A progressive and a so-called land of liberty, land of freedom, is ushering in regressive law, the abortion law. State of Texas has passed one of the most regressive law. It bans abortion after 6 weeks of pregnancy, though in USA, by 22 weeks, pregnancy is allowed. So, and most women don't even detect pregnancy within the first 6 weeks. And doctors can be sued if they do abortion after 6 weeks. State of Mississippi is asking to re-examine the legal rights of women for abortion. American women can lose their right over their own body. Why is the world so anti-abortion? Why is the world so anti-abortion? Have you noticed that most of the countries that outlaw abortion are in Latin America, a region where Catholic Church has immense influence? It believes abortion is murder. There are myths about abortion. So let me first burst myths one by one. The first myth is the fetus feels the pain. The truth is, the fetus can only start feeling the pain or any sensation for that matter around 26 weeks. According to Royal College of Obstetricians and Gynecologists, fetal perception of pain can occur only after 24 weeks of gestation. Cortical processing and therefore any perception can occur after that. The second myth is abortion causes depression, abortion trauma syndrome. The truth is there is no medical condition like this. Look at the Turnaway study in USA that has researched and spoken to over 1,000 females of the reproductive age in across 30 abortion clinics. Researchers spoke to women who went through abortion and to those who were denied it. So women who were denied abortion were more likely to experience serious complications like depression. They were more likely to stay tethered to their abusive partners, more likely to have serious complications during pregnancy or during delivery, including death. So if you are concerned about women's mental health, allow her to make the choice to have or not to have the baby. So why women choose abortion, like my respected ma'am has already mentioned. So there are some unforeseen economic conditions, there are social conditions, job loss, even death of a partner or divorce from the partner. There is threat to health or an unwanted pregnancy. That is why women choose abortion. These conditions make women physically, mentally, financially unfit to give birth. There are times when her health doesn't permit it. Sometimes a woman is not just ready to have a pregnancy. But instead of helping her out, the world and the anti-abortionists wants to close all doors. So there are a lot of countries that prohibit abortion. So let me now talk about the pros and cons on abortion issue. A woman has a right to make decisions that involve her body. A fetus is part of a woman's body because it is dependent on her for survival in the womb. People who are against it say that while a woman has power over her body and can choose how she would like to use it, laws can restrict her control when she abuses the right of others. They say fetus is a separate, living human being whose rights begin in the womb and extend after birth. Matthew Green believes that the right to control one's body can never surpass the basic human rights of the fetus. So according to them, women have no right to use that right and choose abortion. So do not consider an unborn child as a person who must be protected. A baby only becomes a legal person after he or she is born. Anti-abortionists say that people who consider abortion are cruel. It is as cruel as murder. No woman or man should have the power to decide if a baby is allowed to live. I say an unborn baby is just more than just a potential life. And they say no one, but only God has the right to take someone's life. If the fetus would be likely to born defective, you have to abort them. If the pregnancy was a result of rape, abortion is must to save mother's life when the pregnancy would threaten the woman's life or health. But they say if becoming ill gives someone the right to kill, then we should say the law is wrong. Rape is a crime, and they say so is abortion, one in the legal sense and other in the spiritual sense. A preborn child could not reap the punishment for the crime against the mother. So if the mother is a survivor of rape or incest, the preborn child should not reap the punishment. So if you outlaw the abortion, only the outlaws will perform abortion.
Madam?
Yes.
You have to...
Yes. Sure. So countries that prohibit abortion, 26 countries in the world totally ban abortion, 90 million women of reproductive age are affected, 39 countries totally ban abortion unless a woman's life is under threat. SAARC countries like Afghanistan, Bangladesh, Bhutan, Sri Lanka all have this law. 360 million women, that is 22% of women of reproductive age are affected by this law. India, though, is a shining example. Yesterday, the Supreme Court gave a, historic judgment. It says the India's right to abortion is not linked to marital status, and all women have the right to abortion, married or unmarried. So, do you remember those protests? It was in response to the draconian law by the US court. In one blow, millions of women lost their right over their own bodies. It felt like a slippery slope that many countries would follow. Luckily, that's not the case. The Indian Supreme Court has given this historic verdict, and it has said, let me quote, "The artificial distinction between married and unmarried women can't be sustained. Women must have autonomy to have free exercise on these rights. The fetus relies on the woman's body to sustain. the decision to terminate it is firmly rooted in their right of bodily autonomy. And why do we have these anti-abortion laws? There was this slide. Because 77% of anti-abortion leaders are men, and 100% of men will never get pregnant. This is my body, which I control. The men don't control. Thank you. My right to have or not to have my baby. Thank you. Thank you, ma'am.
हमारा presentation कर दीजिए. I'll manage. Don't worry. Friends, now please listen to the other part of the problem. The first point, I would like to give 9 major points. The first point is rights. A lot of things have been said about right. Then my right. My right, as a woman, I will say, my baby is the fruit of my love with my husband. My husband, who is my Lord, my God, my Parmeshwar. My baby is a gift from God. I must accept it and ensure no harm to my baby. I am incomplete without a baby. My family, both my parental and my in-laws, they eagerly look forward to my new arrival, the baby. My daughter says, "Mommy, when is my brother coming?" My son says, "Mommy, where is my sister coming?" Both look forward. The society also expects me to have a baby after my marriage. So I want to assert my right to have my baby. Then comes the right of the baby. Baby who cannot defend. A baby who's helpless. It is not only, it is my duty to defend the right of the baby. Then what about the right of the father? The father also wants a baby. So I think there are 3 rights that are involved which need to be protected. Then the Hippocratic Oath. The oath to save life, not to take life. My teacher, Professor Kutty at King George's Medical University, never did a single abortion. She said, I am to give babies, not to kill babies. So this is the Hippocratic Oath. Then what about the society? We are all living in the society. We cannot ignore the society. Abortions will erode the institution of society. And the state never takes care of people. It is the families that take care. The maximum the state can provide is the hospital, doctors and medicines. But who will take the person to the hospital? Who will give the tablets to the patient? It is the family. So we want to preserve the institution of family. Now, let us look at the other side of the coin. If abortions are allowed freely, what is going to be the repercussions? Oh my God, it is going to encourage sex out of marriage, promiscuity, adultery, rape, sex crimes, whatnot, sexually transmitted diseases, and adverse effects on the institution of family. The most interesting part here is that the men are silent, totally silent about their rights. Biden never talked about his rights, never. Neither the positive rights, neither the negative rights. Because they want to have it both ways. See, it is probably the men will benefit the maximum with the abortion law. If you allow law, they will be because men are usually not able to control their sex. Women are relatively, of course, they may have problems, but women relatively are able to control because societal pressure is very high. So the men will have a free hand to have sex because there's no risk. You have sex, oh, go, girwa do, get it aborted. So but men are silent. No man has talked about men's rights. Now, look at the ethical part of it. Abortion is a grave sin against my own baby, my other baby who wants a sibling, and against the law of nature. It is God's wish that I should have a baby. Who am I to terminate it? It is the arrangement made by God. And it is not only a murder, it is a heinous murder. Religion forbids abortion. Islam is very clear about it, and so is Christianity. And Hindus also do not endorse abortion. Now let's look at the legal aspect. Dr. Ruma, my learned colleague, has talked about the rights of the mother. Let me clarify here. Rights are always taken in the positive sense, not in the negative sense. We have the parallel example of suicide. You don't have a right to die. It's your life. You don't have a right to die. You have a right to live. Similarly, the right is to save your baby, not to kill your baby. And the other thing that people should know, that no rights are absolute, and they can be taken away by appropriate legislation. And there has to be balance between your rights and other people's rights, rights of your father, rights of your baby, and so on. And the most important thing which needs to be emphasized is that laws have been short-sighted. The judiciary has regressed earlier. Now, of course, things are improving. And regression I am saying because they are looking at the immediate solutions. Oh, how will this girl live? She has been raped, so best to get her aborted. But nobody is looking at who raped her, why did he rape, and how we can stop these things. Nobody is looking at those things. So you can say that the society and the people have regressed and they are not going in the proper direction. But God has His own way of doing justice. And the correction has been done by the Supreme Court of the United States on 24th June 2022 by overturning the two landmark judgments which had allowed, permitted abortion during the first trimester or till the period of, or before viability. Now, the other thing is that it has been emphasized again and again that abortion should be allowed, and they are giving reasons for it. My submission here is abortion is an inappropriate response to an unwanted pregnancy, and one should go for appropriate response. And as you all know that with the modernization and globalization, the infertility rates are rising, and this is leading to increased demands for IVF and surrogacy. Now, both these provisions are highly unethical because the rich exploit the poor. It cannot be accepted that a woman who keeps the woman for 9 months in her uterus, she has to give away the baby after birth just for some amount of money. So it's highly unethical. So the adoption is definitely the better option. And the other, in many cases, marriage could also be a good option where courts have allowed marriage to the person who has raped the minor. And the another option which I propose is that in such cases, if marriage cannot take place, it should be the law should be made to make it akin to divorce, where the person who has raped must give a very handsome amount equal to alimony so that the woman is able to go further in her life. Then what about it's very easy to say abortion should be allowed, but what about the harmful effects of abortion, death, complications, infertility, brain damage, and the other penal provisions are there if it is done in an illegal manner. So these complications are also there, when one goes for abortion. And I just want to quote the study from Mumbai. This is a study which has given very interesting data that in 1972, you find that the ratio between empty pregnancies and abortion was 10:1, whereas in 1978, you find that a number of abortions has increased substantially. So it seems in the coming years, the population will come down drastically because most people will have only abortion and not live births. And the other thing is, it also showed that many people actually did die during the abortion in the second trimester, and also thereafter when they came to the emergency. Then there are also studies which have shown that the drugs, the abortifacients, the mifepristone, this was a big study was conducted by FDA, and it was found that there were 20 deaths and 529 life-threatening complications, and many of them were very, very severe. And so this shows that actually even the drugs are not safe. So this is what we need to say. And the last point that I would like to say, abortion is a double exploitation of the woman. First the man, he makes her pregnant, either as a married or unmarried or as a minor, and then he wants to get a license to go free, so he gets it aborted. So women don't understand this, and I would say this is a double exploitation. This is the ugly face of patriarchy. Men are supposed to take care of the woman and not to exploit the woman. So the take-home message is, don't kill the baby. If you don't want it, give it to someone who wants it. Prevent unwanted pregnancies and rectify them. And last but not the least, sexual continence. Yoga, the first step of yoga is yam, social abstinence, where what is mentioned is brahmacharya, which means sexual restraint. So people must learn how to control their sexual instincts. So this is very important message that I would like to give you. And with these words, I would just like to mention 2 lines, what Mother Teresa said. I feel the greatest destroyer of peace today is abortion, because it is a war against the child, a direct killing of the innocent child, murder by the mother herself, Mother Teresa. Thank you very much for your patient listening. Is Dr. Nirmal here? He may like to give 1 or 2 comments. He wanted to say something. Okay. We can have some discussion. Anybody would like to make a comment here? 1 or 2 comments?
Madam, time is over.
Okay. Okay, if we cannot have a comment, I would just like people to raise their hands who are in favor of abortion. Right, 6. So 6 people are in favor of abortion. And should I presume that the remaining are not in favor of abortion?
No, you can't presume that. Some people don't have an opinion.
Okay then, thank you very much. Thank you very much. Okay.
And abortion is not killing a child, it is just taking out an unwanted fetus.
Thank you for your nice debate. Now, due to your time shortage, we are very sorry that we cannot take any questions. And now the crest giving ceremony. I would like to request Professor Dr. Bidhan Ranjan Rai Poddar to give crest to our speakers. I would like to welcome Dr. Mohit Kamal sir in the stage for receiving the crest. Thank you. Now I would like to request Dr. Bidhan Ranjan Rai sir to give grace to our next presenters. Thank you very much. I would like to request Professor Dr. Muhammad Farooq Alam sir, please come on the stage and provide the crest to our chair, Professor Dr. Bidhan Ranjan. Now I would like to request our chairperson for closing the session and the closing statement.
In the absence of my co-chair, I am the monarch of all I survey. But alas, my time is so short and power is so limited. I have to say only thanks to the presenter. Our first presenter, Professor Mohit Kamal, he has presented a study done during this COVID pandemic, and actually he has validated our expected result. That is, when stress increases, we know the symptoms of OCD increases. Another thing, during COVID pandemic, we have taught our public to wash their hands ritualistically. So we have encouraged the OCD behaviors. So it is expected that OCD will be increased in this time. And the second part of this session, what is lively debate, and as I am not a judge, I have nothing to say about this debate, and as I am a president of this session, and I cannot say in favor of anyone. May I have some opinion about this, but I cannot say this. I only share a news with you, a very interesting news, but as the news is not from the part of our leading Western media, so we don't know the news. The news is, recently there is a referendum in Cuba. It was done, the referendum was on 25th September this year. The referendum was about some law regarding family matters. In this referendum, 67% of the voters vote for equal marriage right for all persons, that is irrespective of their sexual orientation. And at the same time, it also gives rights to adaptation. Irrespective of their sexual orientation. They give right to the surrogate mother and recognizes women's household work. They also recognizes the role of grandparents in the family. I think all these things are very expected things of democracy, which has been passed in a small country like Cuba, and which is absent from our leading media. I will request you to follow this, and it is an example how the human rights, equal rights can be actualized in a country. I'm not extending my talk. I'm ending this session and thanking everyone who participated and make success this session. Thank you.
Thank you, sir, and thank you everyone for patience hearing. Now it's lunch break. At 2:30 p.m., we will meet in 3 separate halls for our oral presentations.